So we'll start this webinar. Thank you very much, everybody, for joining us on this final webinar for the Data Science in the News sessions. So we're going to talk today about a moment on men's health. And I'd first like to start with an acknowledgement of the Turrbal and Yagara people as the First Nations owners of the land where QUT now stands. We pay our respects to their elders, laws, customs and creation spirits. And we recognise that these lands have always been places of teaching, research and learning. I'm Kerry Mangerson. I'm the Director of the Centre for Data Science and I'm your facilitator for the webinar today. And this November, the QUT Centre for Data Science is participating in Movember to create awareness surrounding men's health and wellbeing. So in addition to fundraising and our recent picnic in the park, this month's Data Science in the News will explore the role that data plays in improving men's health and wellbeing. We recognise that this webinar is also shared in the organisation with the Queensland Academy of the Arts and Sciences, and I know that the Academy also has a big focus on men's health. In 2022, the Australian Government Department of Health and Aged Care released a National Men's Health Strategy 2020 to 2030. This strategy outlines Australia's national approach to improving the health of men and boys, particularly those at greatest risk of poor health, and to reducing inequities between different groups. Now, we know that this is a complex issue and that while much is being done, there are still major challenges related to men's health. And today we're going to hear about some of those challenges and some of the innovative solutions. We're really fortunate to have an excellent panel of experts with us to discuss this topic. We have Professor Daniel Johnson from the School of Computer Science at QUT, Jacquie McGraw, who's a PhD student in the QUT Business School. We have Dr. Stephen Corporal, Centre for Data Science at QUT, and Owen Forbes, the PhD candidate in the Centre for Data Science here at QUT. So we have a great range of speakers. I'll just go through again and ask the speakers just to raise your hand so that people can see who you are. We've got Daniel, we've got Jacquie, we've got Stephen, and we've got Owen. So welcome to the speakers. And today what we're going to do is to hear from each speaker for about 5 minutes, and then we're going to wrap up with some questions. Now, if you as listeners would like to ask the panel members a question, then please put the question in the chat and we can come to these at the end of the session. If any of the panelists would like to answer those questions as we go, then that's fantastic as well. So let's start. Our first speaker is Professor Daniel Johnson. So Daniel leads the QUT Games Research and Interaction Design Lab and is a professor in the Bachelor of Games and Interactive Entertainment. So you might go, as I did, what's that got to do with men's health? Well, Daniel's worked in the games industry with companies such as Next Gen Videos and the Binary Mill, and his research interests includes motivations for video game play, the player experience, the impact of video games on wellbeing, and gamification. And Daniel's going to tell us the link between what his research and men's health by focusing on tackling men's mental health shoulder to shoulder. Over to you, Daniel.
Thanks, Kerry, and thanks very much for this opportunity to speak about a topic that's very near and dear to my heart. As Kerry mentioned, my focus is on men's mental health in this space. And I thought I'd start with just some sort of facts and figures. Makes it sound boring, but some observations that are a motivation for a lot of the work we've done in this space. And you know, we know that 1 in 2 people will experience a mental health issue during their lifetime, but what's sometimes less often talked about is that men have a lot lower rates of help seeking. They're not comfortable with the structured mental health interventions that are more commonly the way that we as a society deal with these things, at least in Western cultures. And they have this real stigma, and of course I'm speaking in generalities here, but there's a real stigma for many men around mental health issues being associated with weakness. And there's a number of masculine norms that make it really hard for men to not just seek help, but even admit there might be an issue. And these barriers have really severe consequences, right? Men are more than 3 times likely to die by suicide than women in many countries, including Australia. And so, you know, talking a little bit more about the norms that are a concern here, there's stuff about, you know, independence and toughness and resilience that lead to a lot lower help seeking, and this whole notion of self-reliance. And so as awareness has increased of this sort of thing, what we've seen in the space is that there's, to provide better mental health support for men, there's a lot more targeted initiatives that have been developed. But so many of these, and this explains my what might look like slightly obtuse imagery, are really focused around sport. And those have been great. But, you know, not all men are into sport. So we looked at that, and we also looked at the fact that the more broadly successful interventions with men tend to be action-based as opposed to talk-based, and they tend to follow really instrumental activities, so doing things. So our work in the space has really been along those lines. So the first project that I'll mention here is one that was funded by Movember. We undertook it in collaboration with the AFL Players Association, but we wanted to, in light of what I just mentioned, we wanted to not just focus on sport, but also on video games. So we made an app that brought together a whole bunch of, these are the little modules that we put together that were a whole bunch of key things. I won't get too distracted, but it covered things like mindfulness. It covered things like communication. And we wanted to draw on both the sport and the video games. So we had things like AFL players. They were fantastic in getting involved with the project, leading mindfulness meditations or talking about times that acknowledging tough times that they'd had and how they dealt with them. And we combine those modules. That's one of the videos that we used. Obviously, it's a still image, but with games that we tried to embed lessons around wellbeing and that sort of thing. We found we were very successful when I'm talking about a large team there, but we found a number of improvements. We had the longitudinal, a prospective study, a multi-time point study. We got improvements in well-being, help seeking, sense of connection, and sense of belonging to the community. So we learn a lot from it in terms of some of those things I was talking about. You know, some of that knowledge was still developing, but we found that the really kind of hands-on nature of it, the hooking it to things and spaces that men already inhabited was really important for the project. And like I say, we were happy with the results. We had another project in collaboration with Movember. This one was called Well Played. It was, what we wanted to do there was, again, thinking about the fact that not all men are into sport. We wanted to try, and also with video games, there's a lot of connection and play together that occurs, but so much of it is built around skill levels. So there are ways to jump online and be connected with other people, but it's almost all focused on how good a player you are and matching you for a competitive match. And we wanted to see, well, what would happen if we tried to match people on a different series of constructs? So we looked at communication, skill, friendliness, teamwork, and fun. And we found a great deal of support for the idea. We had a moderate degree of success. There's some practical issues that we didn't really anticipate, but we were able to bring groups of players together. Much like with MindMax, we didn't say only men are allowed in these spaces. We just tried to market them in a way that we knew would appeal to men, and then everyone was welcome. So we ran a series of events and brought a number of people together. The third one I wanted to talk about, and I'll do it briefly because I'm aware of the time, Kerry, is we've most recently looked at pinball as a hobby, and we did a series of interviews with men who play pinball to find out how they experienced it, whether there were mental health benefits, and we were interested in whether it might be another space for a targeted mental health initiative. I'll say, I won't speak too much about this, but just to say we found a number of really positive signs around relating to others. We pinball, because it's an activity in which you take turns, because you stand and look at the machine rather than looking into each other's eyes or face to face, and that turn taking gives you a chance to talk a bit, and then if you're talking about something difficult, you can then switch back to talking about the pinball. So it was really promising, and we saw a number of really strong benefits there that I can talk more about another time. Thanks, Kerry.
Thanks very much, Daniel. That's so intriguing. Thank you very much. I'm going to now ask Jacquie McGraw to speak. So Jacquie has just completed her PhD in the School of Advertising, Marketing and Public Relations. Again, you go, what's the connection? But Jacquie's research has examined men's customer experience of vulnerability when using transformative health services and the role of masculine norms and value destruction. So I'm keen to know what value destruction is, Jacquie. And her previous research has included investigating men's help-seeking behaviours and the role of masculine identities. So prior to her postgraduate studies, Jacquie worked as a social marketer for Queensland Health, delivering health behaviour change campaigns such as making number 2 your number 1 priority. So this is primarily targeted to men to participate in bowel cancer screening. So Jacquie's going to talk to us today about boomer bravado to zoomer zen, the role of masculinity in Australian men's health service use across 4 social generations using data from the 10 to men study. Over to you, Jacquie.
Thank you, Kerry. I don't think I could have chosen a longer title for my presentation if I tried. Sorry about that. Yes, thank you. Yes, I've been researching men's health, as you said, for about past 6 years now, and before that, and that's what got me into men's health and interested in why men aren't using preventative health services, is my work with that campaign, that bowel cancer screening campaign. And you mentioned that transformative services, and that this is where my discipline is looking at men, not just men, but anyone who's using a health service as a customer rather than a patient. So when Daniel's talk just before, talking about masculine norms, was really, I really resonated with that, because that's exactly what I've been doing. I've been examining masculine norms consistently for the last 6 years. So 2 of my PhD studies were using data from the 10 to men study. So the 10 to men study is a longitudinal study in male health that's happening in Australia. It's been, was first wave of data collection was in 2013, and it's still going on. They're about to look at their 4th wave of data collection. So 2 of my studies, I had access, was fortunate enough to get access to this data for my PhD, and there's 16,000 males have participated in the first wave of this, males aged 10 to 55 at the time. And I've been looking at, one of the great things about this study, not only does it encompass 4 different social generations, but it also measured in the first wave, particularly traditional masculine norms and conformity to traditional masculine norms with the young men at the time, 15 to 18, 17, and then the adults. So what I did was, how they measured it was with this instrument for measuring masculine norms, which has been used quite widely. It is a little bit older now, but I think that there's limitations when you're doing such a massive public health survey with using instruments that are trying to glean so much information. So it was an instrument that had 11 norms, and you can look at different norms and also conformity to those norms, and also the overall score, which was adding up those norms. And this was the sample that I looked at in wave 1 of 15 to 55-year-olds, and that was their overall score for the whole sample. But when I divvied it up into generations, the 4 generations, comparing the mean scores of those generations of conformity to overall traditional masculinity, it was a bit surprising. It was showing us that the younger men, younger generations, had higher conformity scores than the older generations, which we're a bit surprised about. And my supervisors made sure I actually got that right, and had to calculate it quite a few times just to make sure that was right, because what we're reading in the literature was that things are changing. There's a shift in masculinity. Younger generations are becoming a little less traditional, and things might be changing. But this is an Australian population. So that was a little bit interesting, a little bit maybe concerning for some. But what does that mean for health service use? Then I looked at the different generations and their use of health services, preventative health services and primary health services. And Kerry, you'll have to just give me a hoy because my timer has stopped working. And so I looked at the different specific norms because I wasn't getting much information out of the overall masculinity scores, but certainly was getting something from the specific norms. And these norms tell us if a person in that generation group is likely to conform to that norm, are they likely to have increased regular use of a health service or decreased regular use of a health service. And you can see that there's not many influential norms for the Generation Z there, and also not many for baby boomers, except there are some norms here for decreased regular preventative health service use. So if they conform to those norms, they're less likely to regularly use those services. However, I did find that there were some norms that were influential in increased use of regular service. So some of these norms are not ideal norms and they're not the sort of norms we want to be promoting, but some of them we could use and somehow leverage those norms to help promote the using of services. And I thought it was really interesting, Daniel's talking about winning, for instance, with with gaming, and that sort of might be able to leverage that norm further. And there's some interesting norms there too. So then my next study, just quickly, was looking at, well, maybe men are actually, because these norms are prohibiting him from using services, maybe they're actually experiencing customer vulnerability. And in services marketing, anyone can experience customer vulnerability in a service situation, and particularly in health service. If you think about it, you can feel vulnerable in that service when you're using that service. So there's different interpretations of what vulnerability is, but in services, anyone can experience customer vulnerability. So what I did was I grouped them all into 3 groups using a process called latent class analysis to look at different groups and whether I wanted to find out if any of these groups and what their characteristics would be experience customer vulnerability or likely to experience customer vulnerability in a preventative health service. And this was with adults in this situation, because the adults in the data only asked that question. And I found 3 groups came through from that analysis. 2 of them, and I named them according to the norms that they were conformed with. So over 3, they conformed to those particular norms. Under 3 means they did not conform to those norms. So there was a group that had no conformity to only 1, which was status, and that I called them modern status. And then the other 2 groups were traditional bravado and traditional self-reliant, because of the norms they conformed to. But then I found also in that analysis that actually that all of them responded that they weren't likely to go to a doctor if they were sick, and therefore they were, in my analysis, would be likely to experience customer vulnerability in preventative health service. And then I looked at it over time, and we can see over time, looking at that same question, underneath means that they're not likely to use the service regularly, and over the line means they are. The modern group, the group modern status that didn't conform to many norms or only 1, were more likely to start regularly using than the traditional groups. And this group here is the self-reliant group, and Daniel mentioned self-reliance. It's a very problematic norm for men and health behaviours, and so they also they'll get out of it. They will regularly use the service one day, but not for a very long time. And also, this is across 7 years, if you see the years there. And then I also looked at wellbeing and overall subjective wellbeing. And while these 2 groups were sort of near the normative range for Australian subjective wellbeing scores, this self-reliant group was very low, had very low subjective wellbeing. So that suggests that there is a vulnerability or experience of vulnerability in the service there. Yeah, so I'll just stop sharing. But yes, the value destruction you mentioned, Kerry, that sort of led me to my third study, which was looking, something's going on in the service, that men aren't enjoying the service, they're not using the service, there's something, the value of the service isn't appealing to them. So then I have gone on to look at how is the value of the service being destroyed for men.
Oh, thank you so much, Jackie. I learned so much from that, and it's really intriguing and great analysis. Thank you. Thank you for sharing.
Thanks for asking.
And so our third speaker is Dr. Stephen Corporal. So Stephen works at QUT as a research fellow in our Centre for Data Science, and he's a sessional tutor in the School of Public Health and Social Work in the unit Health Needs of Aboriginal and Torres Strait Islander Australians. I can't think of anybody who would be better placed to talk in this panel. So thank you, Stephen. He recently completed a PhD entitled Identity, Roles and Expectations, the influence of those on Indigenous university students when they're building the Indigenous health workforce. So this was done at Griffith University, and he also has a grad cert in Indigenous leadership and research at the University of Melbourne. He's currently Deputy Chair of the Indigenous Allied Health Australia Northern Territory Workforce Development, and he's been involved in counselling and welfare work and as a board director on various organisations in the Brisbane Aboriginal and Torres Strait Islander community for many years. So over to you, Stephen, to talk about Indigenous men's health gap.
Thank you, Kerry. I'll just share my screen. I will try to make it go fast as possible.
No, please don't. We want to hear what you have to say.
Can you see that screen okay?
Yes, that's great.
Oh, good. Okay. I wanted to focus today on Indigenous men's, on the health gap. And as we've already acknowledged the traditional custodians, I like to put that up there. And part of understanding Indigenous people, one of the things that I like to show everyone is that you can't apply one thing in one area because it's such a diverse population. So I like to show that map there to say, and some of the history of data is one of the main things was that Aboriginal and Torres Strait Islander people weren't counted in when Australia became a nation. They weren't counted until 1971, after they had a referendum in 67. And considerations of data, Indigenous data, and more recently people have been talking about, it's to do with self-identification. And what happens is sometimes people may not identify, or they may identify. So I'll leave that there. I won't read it all that. And also, one other thing to think of is sometimes Indigenous data has been used as deficit data a lot of the times. Professor Maggie Walter, she talks about this a lot, and got some links there if people want to look at them later. Anyhow, we like to show this pyramid, and the light blue there that you see is the Indigenous men. So we have a lot of younger Indigenous men, but by the time they get up to about my age, up the top here, we're starting to be a lot less than other men. And same with the women. And when we get to there, we start getting worried about our life expectancy. And anyhow, and with life expectancy, it's about when people are dying as well. And as you see in this one, the light blue, a lot of the Indigenous people are dying at higher rates here at younger ages. And, you know, like we'd all like to go till 85, but you see that the most are going around 60 to 64. I shouldn't laugh. I'm in that age group. Anyhow, it's quite interesting. I pulled most of this from the ABS. It's about the international comparison says that Australia is actually 5th in the world for life expectancy. And, you know, you sort of think, okay, how come Indigenous men are a lot further down than that? And that's one of the charts over the years. It's gone up of everyone with life expectancy in Australia, and it's good that it's risen up 5th in the world. So this here, I pull these off. It sort of says 2015 to 2017. I couldn't find the actual 2020-21, but it's sort of that same picture of saying, look, Indigenous men is average of 8.6 years, you know, life expectancy. There's a gap there between other men, and the women are much higher as well. Even the Indigenous women are higher than the Indigenous men. The gap, even though it's been reduced over the years, it's sort of still, there's a gap there, and we're trying to work out why this gap is there. And it's remained the same over the years, this gap. And not to be too focused on deficit, but just saying, okay, what's going on? And why there's a gap is, I know from working and teaching in a lot of Indigenous courses and continue, is we talk about ongoing colonisation, and there's a breakdown of connection to land, culture, spirituality and community. And also Indigenous men susceptible to poor mental health, suicide due to discrimination, and there's a lot of, sad to say, in our communities we have ongoing suicides of young and older Indigenous men. And also with the hospital rates, it was sort of similar to what you were saying there before. We're saying the hospital rates are higher, but what's happened is that the reason it's higher is a lot of Indigenous men won't go to hospital or to see a health profession, and so until it's too late, and then it sort of becomes higher. And also one of the imprisonment rates is 11 times the rate of general male population. So that puts a lot of emotional strain on, not even talking about deaths in custody, but it puts a lot of strain on the Indigenous men. And I got that off NACHO, which is the National Aboriginal Health Organisation. And this one here, I was saying, going through this fast for us, is what can we do about the gap? Is like you decolonise how you work with Indigenous men to address the ongoing colonisation, like and about cultural safety, providing cultural safety, cultural responsiveness workplace. Do Indigenous men feel safe in your workplace? Is it putting emotional stress on them? And NACHO, I like this statement that says upholds traditional values of respect for the law, elders, culture and traditions, responsibility as leaders and men, holders of the law, providers, warriors, protectors of their families. And sad to say, a lot of colonisation has impacted upon this, where that authority of Indigenous men has been lost in the communities. And you see that, you will see that through a lot of, you'll see it through a lot of things, such as children being removed. The fathers may not have a say in that. Anyhow, one of the things is about connecting to land, culture, spirituality, family. It sometimes that will actually, if you connect men in with what was lost, their land, their culture, spirituality. I left this one here. It was off the Nacho website about the ink at the men's health shed or men's shed. Sometimes is connecting men with other men, bringing them together in a, to say, hey, come on, let's get how you going and that. And sometimes that's to get men to focus on their overall health. And I know with COVID, I actually lost a couple of good mates through COVID and their health, and they're gone. Encourage Indigenous men to have regular, comprehensive, a 715. Is anyone? Well, a 715 is a health check, and we call it that. And one of the ones that does it a lot is the local Aboriginal Health Services. I go to my local doctor, and he actually does a 715 there, a health check. So, and when I haven't got it down here, but with the they have the footballers, all the footballers, they like to do the 715s when all the Aboriginal people come together at the football to check, give them a health check. And it's been, I think some of that's really good at where they're saying to people, you need to connect in there because as previous speakers were saying, us men, we don't like going to the health service, and at the top of this, where I was saying, like, it's that cultural aspect. That's why I'm saying is that why a lot of men, they'd lost their cultural responsibilities, but then they're, like still that thing of not wanting to go to health services. It's quite what's the name? Quite clear that a lot of the times. Yeah, so that's it, Kerry, and others. Thank you.
Thanks very much, Stephen. That's sobering information, and certainly something that needs to be brought to the fore, and for all of us to recognise and then figure out, how to do something about that. And I really like the way that you talked about like what we can do as individuals. So thank you. Our last speaker in this session is Owen Forbes, and Owen is a PhD student in the School of Mathematical Sciences at QUT, and he's researching novel statistical methods for analysing complex longitudinal data sets. And in particular, he's relating brain activity to mental health and distress outcomes over time. And he has a focus on adolescent development with clinical relevance for risk prediction and early intervention. I'm going to hand over to Owen to talk about data-driven perspectives on mental health. Over to you, Owen.
Before I start, I'd like to pay my respect to the Ngunnawal and Ngambri people as the First Nations owners of the land where I'm joining from here in Canberra, and to reflect that wherever we are in Australia, we're gathered on stolen land and that sovereignty was never ceded. Today, I'm going to be talking about how data science can offer some exciting ways forward for building better understanding of mental health and how it's experienced differently across different gender groups. And just a content notification that I will be talking about some subject matter related to suicide and self-harm. So the latest statistics from the Australian Bureau of Statistics show that 1 in 5 Australians, as raised by Daniel, will experience a mental health concern in the last year, and 18% of men and 25% of women. In terms of suicidal thoughts and behaviors, women tend to have higher rates than men in terms of suicidal ideation and attempted suicide. And then when we think about groups like trans and gender diverse populations, including trans men, we know that they have 10 to 15 higher times rates of attempted suicide than the broader population. We know that more generally, trans and gender diverse populations tend to experience much higher rates of mental health challenges. But unfortunately, official statistics aren't generally readily available on the incidence of mental health issues in trans and gender diverse populations. So for the most part in this talk, I'll focus on gender binary categories of men and women. Looking at comparing men and women, some of these stats have been raised by the earlier speakers. So we know that men die by suicide at a 3 times higher rate than women. Men are twice as likely than women to have an incidence of substance use disorders. And in terms of help seeking, men are only 60% as likely to seek help for mental health concerns from professional healthcare providers. And so looking at these stats, they really raise a bunch of concerning questions like, why are the rates of mental health issues so high in trans and gender diverse populations? Why are men more likely to experience problems with things like substance use, while women are more likely to experience things like anxiety disorders? And why are so many men dying by suicide? When we're trying to answer these questions, we're really held back by some substantial flaws in the current traditional approaches that we use to categorize and think about mental health. So currently the thresholds that are used in a clinical context with tools like the DSM, they're really based on clinician opinion and they can be quite arbitrary. And accordingly, it ends up that there's a lot of overlapping symptoms and a lack of clear boundaries between mental disorders. And then looking at a gendered lens, studies in the US and Germany have shown that when men and women present in a clinical context with almost identical symptoms, men are much less likely to receive a diagnosis of depression than women. And we see this trend repeated. So the way that we kind of label and interpret mental health symptoms is colored by our expectations of gendered behavior. So for instance, boys are 3 times as likely to be diagnosed with ADHD compared to girls. And there's growing recent evidence that this is in large part due to kind of bias in clinicians' gendered expectations of behavior in children. So in response to a number of the shortcomings that are present in these traditional approaches to categorizing and thinking about mental health, more recent research efforts, they emphasize using data science to study in detail how patterns of mental health symptoms co-occur. And these approaches look at things like how data-driven patterns of symptoms occur together to come up with dimensional diagnostic models that have more clear boundaries between diagnoses and reduced heterogeneity within each diagnosis. And while these approaches can't address kind of more widespread issues like unconscious gender bias and different socialized expectations of gendered behavior, they can go some way towards addressing how we might better treat and identify mental health issues across different gender groups. So looking at an example of one of the big data-driven efforts to redefine categories of mental health problems, which is this hierarchical taxonomy of psychopathology, there are broadly a lot of similarities in how these symptoms occur across gender groups. However, these approaches to data-driven mental health research have revealed some kind of substantial differences in how groups of mental health symptoms occur by gender and have some suggestions about how we might improve going about prevention and treatment. For example, women are more likely to experience internalizing spectrum disorders, including things like mood and anxiety disorders. And so prevention strategies for women might do better if they focus on things like interventions around rumination and cognitive restructuring. Whereas for men, men are more likely to experience things like disinhibition and externalizing spectrum disorders, such as substance use or antisocial personality disorder. And accordingly, this evidence suggests that prevention in men might do better if it focuses on things like shaping disinhibited behaviors into less destructive outlets. Just briefly to touch on some of the work that we're doing here at QUT. So another exciting way forward that's offered by data science is, instead of looking at patterns of symptom co-occurrence, we can look at patterns of brain activity. So what we're doing in some of the work that we're doing at the moment is looking at taking measures of brain activity in young people, applying different clustering algorithms to find data-driven groups or phenotypes based on resting state brain activity. And from there, using those clusters as indicators of risk. So comparing what's the gender composition between clusters and what are the different mental health risks and cognitive function levels between those clusters. So for the sake of time, I'll stop there. But if you're interested in finding out more, you can check out the reference here. But yeah, just briefly to touch on a few ways forward, and I can come back to these in the panel discussion, but I think that keeping in mind things like compassionate care and centering lived experience, keeping in mind the different sorts of stigma and risk and help-seeking behaviors, that are experienced among different gender groups. And using data-driven methods that emphasize kind of granular lived experience symptom level data and brain activity patterns have some really exciting opportunities for kind of improved and less limited ways of understanding mental health. And yeah, that's it. Thank you for the invitation to speak today.
Oh, thank you very much, Owen. That's excellent. Okay, so I'm going to open it now to questions, and we have the first question that's in the chat. And so this comes from David Lovell, and David has asked, as groups, men are diverse and women are diverse, and different gender groups have overlapping traits. So we know that men and women who display a range of feminine and masculine traits, just as we know men and women who are taller or shorter than each other. So David's question is, why focus on specific gender groups when it's the traits that are of interest? So I'm going to open it. Who would like to start that conversation?
I'm happy to, Kerry. I had the longest to sit and think about David's question while Daniel was speaking.
Thank you, Daniel.
I think it's a great question, David. But I think there's a number of reasons. One, I think, is when you talk about norms rather than traits, there is no feminine norm for not seeking help. There's only a masculine norm for not seeking help. So while traits might overlap, norms tend not to. Norms tend to be very gendered. I think also, much like with breast cancer, we know both men and women get breast cancer, but it's so much more of an issue for women. So we deliberately target our campaigns around that to women because that's where we can have the most impact. So I think impact is an issue there as well. And there's no stigma for women in seeking help. There is stigma for men in seeking help. So when we're trying to change behavior, I think that's another really good reason to focus that way as well. I think your question raises a good point, which is we shouldn't be blinded by that. But I think that's the reasons that we tend to go in that direction.
Thanks, Daniel. So, Owen, you touched on this as well. So you touched on this as like not looking at the sort of the more traditional classification of mental health, and especially around men and women. So would you like to add a little more to that?
Yeah, I think reading David's question, what it brings to mind for me is that I think there's no one monolithic group of men and no one description of what men's experience of health and stigma will be like. So, you know, today we've thought about young men and Indigenous men and transgender men and older men. Like, I think thinking about each of those groups and, you know, it connects into, I think that it's important in each of those instances to think about really centering the lived experience of the specific demographic that you're trying to reach. So if you're trying to design health services that are approachable and affirming for Indigenous men, then it involves, you know, working with co-design and lived experience to talk about how can these services be designed to be culturally safe and affirming, like Stephen was talking about. I think similarly, you know, for gender diverse communities, I think working with lived experience and representation from those communities to be involved in the design. So yeah, I think that, you know, I appreciate what you're saying, David. I agree that you shouldn't monolithically say that all men will respond in the same way or have the same attitudes around mental health and help seeking. And it's more important to focus on, you know, what the kind of dimensional continual spectra of their experiences are and cater to those more specific tailored elements within that demographic.
Thanks, Owen. Jacquie, what have you seen in the data around this?
Thanks, Kerry. I was just going to agree with what Owen and Daniel have said, and also just from a marketing perspective, a services marketing perspective, when you're trying to talk to and engage different groups, you sometimes have to be specialised, and the research around men's health behaviours and what men respond to are it's genderised or gender sensitive approaches are more effective because they're more relatable to men. And it's when I was delivering the bowel cancer screening campaign, for instance, which I'll go way back, it was targeting men, but it was also targeting women because men had low screening rates. We had a bit of a masculine feel to the campaign, but I think sometimes overarching approaches will work, but clearly we have low use of services. Men's health situation is in a dire situation in a lot of ways, as we've just found out, and in a lot of contexts that we do have to be specialised sometimes in our approaches and try different things to see what's going to cut through.
Thanks, Jacquie. That's really good food for thought. Stephen, in the Indigenous communities, what do you like? What's the story there? How would you respond to David's question?
Yeah, I just, like I was saying with how the ABS, and they pan it out as male and female, you know, men and women in there, and so sometimes that doesn't actually cover all of our Indigenous community, because you may, I don't know if you heard the term, you know, 5 spirits, or and that's saying a lot of that people are from different genders more than just male and female. I don't know if you've, and sometimes, and in Australia we you know, we'll talk about that as well, that we have many groups within our community from the different genders. So we, and when you're, that's part of, as I was saying, with the diversity, when you go to a community, you need to be aware of which group is within that community. And that's very important, because we do have, you know, people from different spirits within our community. Does that make sense?
Yeah, that's excellent. Thank you.
Okay.
Thank you. I'm going to pick up on something else that both Stephen and Jacquie touched on in their presentations, and that's like, what can we do? So, you know, what can we as individuals and what can, as community members do, and communities do in this space? So we've come from like 10 years back to now. We've got 10 years in the future. How, you know, how can we change these figures and this gap? Jacquie, you talked a little bit about that in your study. Would you like to touch on that a little more?
Well, yeah. So I was, through my research, I've been trying to figure out how do we reach men and different ages of men and age groups of men, or different characteristics, men of different characteristics, not just the norms that they conform to, but just trying to find out how do you engage men into thinking differently about their health. And some of the things that you can, like, because I'm coming from a services perspective, so I'm looking at different practical things that practitioners in services could do when whether they're using marketing approaches or using the service to try and attract people, that they could, by understanding, by doing this research, and, like, for instance, finding out that, okay, we're not just going to go, oh, this masculine norm is commonplace, but also this just informs us on how we can approach our strategies and how we can reach particular groups, and that it's nuanced. So rather than saying, oh, we're going to reach all men with this approach that's boosting status, so we see that, oh, actually it's a bit more nuanced than that, and we might have to be more refined on how we're approaching our communications and our messaging, and take that approach. So that's, I think, what we can do with the information we find, is how we use what we know about what we're finding out about men and different groups of men and males and different genders, and how we can use that information to reach them better and be more relatable.
Oh, that's excellent. Thank you. No, that's great. Would anybody else like to comment on that? Like, what's the practical implications of your work? Daniel, so what?
I'm going to answer it the way you asked it the first time, Kerry, which is what we can do, because what I've been trying to do, and what I encourage people to do whenever this comes up, is to model better behavior. So I'm trying to now, and I was so fascinated by Jacquie's graph, but when I hear a young man say something like, I don't really like talking to other people, what I try and do is say, wow, that sounds really silly to me. I think we should be talking to each other. And I think it takes strength and courage to do that, and just try and provide a different narrative. I don't know if it's effective. It's just all I can think of to do when I hear those things. And I think it's about, for me, I think it's about just being prepared to have an awkward moment with someone and go there and say the thing that's difficult to say. Because I think it's so easy to be unsure about whether to say something or to be worried you'll say the wrong thing. And I think that's dangerous. And we're better off having an awkward moment and saying something tricky. And just, yeah.
Okay, thanks, Dan. That's great.
I wanted to finish my thought there, but it wasn't going to, I don't want to do that. So yeah.
That's great. Perfect. Thanks. Owen, do you have anything to add?
Yeah, I guess in terms of practical implications of my work, maybe, yeah, wearing my PhD hat, I think that there's exciting ways forward where we can really use data science to get much more granular insights into how mental health symptoms make up groups of disorders that are experienced specifically and consistently across different people. So, you know, coming up with different ways of organizing our labels of mental health issues in a way that has more clear boundaries and more consistent experience across men and different gender groups. But I think continuing on from what Daniel was saying, you know, taking off my PhD hat and putting my mental health advocate hat on, I think that more generally, you know, as men, but as anyone in a community, you know, spreading the norm of like wearing your vulnerability as strength and spreading the norm that it's not weak to speak, and, you know, that speaking about mental health and sharing our own lived experiences of mental health difficulties is a really powerful way of, I think, spreading the norm that having mental health conversations is normalized and encouraged. And so I think, you know, whether that's happening at the level of colleagues and friends around the water cooler or in institutional messaging, I think that, you know, role modeling openness about mental health, I think, shows a lot of promise, and kind of centering lived experience and allowing people to share their own challenging experiences is a really powerful avenue, I think.
Yeah, thank you. That's excellent. Stephen, I've left you to last because you actually had some really good comments and suggestions in your presentation. Is there anything that you would like to elaborate on?
The one thing I like is you know, a lot of the Aboriginal men get together through sport, but also I have two sons, and they get together through the computer games and that. So there's also that. So it's sort of like having a look at the different ways which young people, how you can engage with them, but also older people. Like tomorrow I'm going for a drive with a whole heap of Indigenous men down to Lismore. That, you know, like, it's a fundraiser thing, but just the getting together and talking with each other, I think is powerful. But not only for men to talk to each other, but for, you know, family to talk with each other, because isolation, I find that isolation is, as people get older, is one of the things that will kill them. And also even with the young people, isolation, mental health, you know, and and that's why I wanted to just give us a talk about those things there. I actually went to an Indigenous men's day one couple of years ago, and that's where I got a lot of that out of. And we had people like Patrick Johnson there. If you don't know Patrick Johnson, he was one of the fastest men in Australia, hold the Australian record for 100 metres. And mate of mine, Derek Chong, he's Dr. Derek Chong, he's a psychiatrist. We were all there and we were just talking about men's health, you know, and I think just getting the men together sometimes to talk about their health, to talk about how they're doing. And that's even if they're at university or in high professions, you know, they need to talk to each other. because if they don't talk to each other, your young people watch them and they go, oh, that's what it's like to be a man. So and not forgetting, you know, when I say this, I say, as I said before, we've got to think that there's other people outside of the masculine roles as well. There's I have some other mates that don't fit those stereotypes of men and need to engage with each other as well.
Yeah, thank you, Stephen. That's great. Okay, we're coming very close to the end of the session. So what I would like to do is just ask each of the members, each of the panel members, to say in 5 words or less, what is the message that you would like to give to the audience about men's health? Okay, so for the people listening, the panel members have had about 30 minutes to think about this. So it's not something that they've prepared really well. So I'm just interested in that sort of short, sharp message. Jacquie.
I got 6 words.
6 is great.
Don't assume men are not vulnerable.
Great. Okay, thank you. Stephen.
Make sure you get your health check.
Great. Daniel.
I was getting nervous. I was thinking, oh, there's only so many different 5-word phrases. Sorry, Owen, I hope you've got something different to this. Model behaviour and check in.
Perfect. Owen.
I think it's important to always foreground men's lived experience in healthcare for men. That's a lot more than 5, but the core is 5.
Perfect. Thank you very much, everybody. It's been such an informative session, and it really does touch on so many aspects of men's health. It's really important for us to focus on this, especially in this month of November. I really appreciate you preparing and for communicating and for the open discussion. It's been great. I have one more question, and that is, Daniel and Owen, are you going to shave your beards for Movember?
I did it one year. I feel like I did my dash the year that I did it. Was the year Movember gave us a lot of funding, and I thought, all right, I've got no choice. Maybe if they fund another big grant.
Okay, great. Owen?
No.
Great. Well, I certainly think you've done your duty and contributed to the cause through this webinar. So thank you very much, everybody. Thank you very much, all the people who've been listening to this webinar. Particular thank you to Becky and Becky Cook and Tim McCougar for organising the webinar, and also to the Queensland Academy of the Arts and Sciences, who together with the Centre for Data Science make these webinars possible. Thank you very much, everybody. We'll close it now.